Hi, everyone. Um, Today, we're going to be talking about thyroid disorder. So this is the fifth video of this academic half-day endocrinology series. So this will be a relatively short video since thyroid disorders itself are not very difficult to understand, but they're very important and they show up quite frequently on the board exam and also in your daily practice. So let's go back to the usual hypothalamic pituitary axis that I've been mentioned in almost every lecture. So again, hypothalamus and pituitary is the central control unit of the thyroid axis as well. So hypothalamus secretes TRH, which stimulates pituitary gland to secrete TSH, right? Remember, TSH is not a thyroid hormone, it's a thyroid stimulating hormone, right? And then the TSH stimulates thyroid gland to secrete T4, which is thyroxine, and T3, which is triiodothyronine, right? So T4 and T3. And then T4 and T3 bind to peripheral organs, which then provide a feedback loop, right? So the majority of circulating thyroid hormone is T4, right? Now, there's a fraction of T3 that was produced by thyroid gland, but majority of T3 occurs by the peripheral conversion, right? So I'm going to be asking you the question on the quiz. The enzyme is called deiodinase enzyme, right? So the deiodinase enzyme, it removes one of the iodine from T4, right? Become T3, right? So number 4 denotes 4 iodine molecules. T3, they have 3 iodine molecules, right? So, but the T3 is actually the active hormone, right? But if you want to measure the state of thyroid gland, you measure T4. Better than T4 is free T4, okay? So again, thyroid hormone is a protein hormone, but its receptor is a nuclear receptor, right? Similar to steroid hormone receptors, right? We talk about in cortisol or aldosterone, those are steroid hormones. The thyroid is just the only one protein hormone that doesn't bind to the surface receptor, but instead it binds to a nuclear receptor. So I'm going to be asking that on the quiz as well. What type of receptor is thyroid hormone receptor, right? So the thyroid hormone receptor, it exists in almost every organ, right? So it's one of the most important hormones that control growth and metabolism. So in primary hypothyroidism, okay, the problem is at the thyroid gland. So for whatever reason, the thyroid gland cannot produce sufficient amount of thyroid hormone. So it sends a positive feedback, right? The end organ sends a positive feedback to hypothalamic pituitary unit, right? To stimulate TSH secretion, right? So a hallmark in primary hypothyroidism is that you have a low thyroid hormone with elevated TSH, right? So that's called primary hypothyroidism. Okay. Now, there's another term that you actually may have heard before. It's called goiter, right? I believe most people have heard of this term before. So goiter is actually the enlargement of thyroid gland, right? So it doesn't tell you hypothyroidism or hyperthyroidism. It can be seen in both, right? You could see goiter in Hashimoto thyroiditis or in Graves' disease. So it's just telling you that the thyroid gland is enlarged. Now, the cause of primary hypothyroidism, one of the most common cause is congenital hypothyroidism, right? Which is mostly caused by thyroidogenesis or ectopic thyroid gland. You can have an infection, right? A very, very serious infection, like viral infection or bacterial infection. Trauma is probably when someone had a thyroidectomy, right? So the whole thyroid gland was removed. Autoimmunity, Hashimoto thyroiditis, right? Remember this name? I'm going to be asking about the question on Dr. Hashimoto, especially the paper that he described Hashimoto. So look that up. So it's been described more than 100 years ago, right? It still stands until today. Okay, so Hashimoto thyroiditis is the most common cause of hypothyroidism in children and adolescents, right? Primary hypothyroidism. But if you talked about congenital hypothyroidism, the most common cause is thyroidogenesis or ectopic thyroid gland. It's actually ectopic thyroid gland is more common than agenesis, right? Or you can have many toxic substances such as medication, right? Many seizure medications, lithium, or iodine itself, right? So when you use the betadine, right? So we saw that there are cases in NICU or a newborn nursery where patients have been like the betadine was used excessively, right? And it's absorbed to the skin and it caused a blockade of thyroid hormone production. Now, when we talk about secondary, right, or central hypothyroidism, the pathology is either at pituitary or hypothalamus, causing a low TSH state, right? And because of low TSH, the thyroid produces low amount of thyroid hormones as well, right? So we call that central hypothyroidism. So when you obtain blood tests, thyroid function tests, you see a low T4 with low TSH or even normal TSH, it's considered a central hypothyroidism. Now, when we talk about etiologies of central hypothyroidism, in congenital, right? So congenital causes mostly refer to hypopituitarism, right? Because you don't have the pituitary function is subnormal, right? For whatever reason, it could be that pituitary gland was not well formed, it's in the wrong place, or part of a complex brain anomaly. Infection is quite rare. We don't see that often, right? Trauma, when we talk about trauma, it could be with some patients with brain surgery or had radiation, right? So especially whole body radiation. Autoimmunity is also rare. Toxic substances, one of the agent that can suppress TRH and TSH secretion is dopamine, right? So you see that in intensive care unit. When you infuse dopamine, it actually suppresses TRH secretion. Now, there is a particular focus on thyroid disorders in newborn, right? So because every state has a screening program to detect congenital hypothyroidism. What does it do? It screens for elevated TSH, right? So the heel prick, one of the tests that they do is TSH level, right? So they look for elevated TSH, right? So it would not pick up central hypothyroidism in newborn, right? Anyway, there is a general consensus that congenital hypothyroidism, central hypothyroidism in newborn does not cause as much brain damage as the primary hypothyroidism, right? So even though the patients will not be picked up, we found that they do not have the same degree of a neurological damage as the primary congenital hypothyroidism. Now, with that being said, when we say congenital hypothyroidism, is almost always refers to primary hypothyroidism, right? The problem at the thyroid gland, right? So again, I mentioned about the most common cause is ectopic thyroid gland or thyroidogenesis. We're going to be doing a case illustrating how to manage a positive newborn screening for thyroid function tests, right? So we're going to be doing that during academic half day. How do we come to the final diagnosis of ectopic thyroid gland, right? There's also the possibility of transmission of maternal antibodies, right? So this is a reason why we did thyroid function tests in infants of the mother with history of thyroid disorder. And the most common cause of acquired thyroid disorder is autoimmune thyroiditis, right? So this is the reason why we did the screening test. So it is supposed to be a transient type, which means that it resolved by 6 months. Now, we have to be careful because newborn screening is such a sensitive test. So it picked up many false positive tests, especially if it's done before 48 hours of life, right? Because there is a physiologic TSH surge, right? Remember, in utero, the pituitary almost produces very low amount of TSH. Once the baby is born, within 30 minutes, the system starts to, become active. So they produce a very large amount of TSH. So it could be up in the hundreds, right? It will come down by 48 hours of life, right? So this is a reason why when you have a positive newborn screening, the first thing you look at is the time of collection, right? If it's done so early, most likely it's a false positive result. Now, there is another condition that many of you guys have seen in the clinic, right? So it's called compensated hypothyroidism or subclinical hypothyroidism, right? So in this case, you have a normal free T4 with just some slight elevation of TSH, right? So that's why it's called subclinical hypothyroidism, right? Because you still can maintain free T4, normal free T4 level. And most cases do not require any treatment, right? So what are the causes? Autoimmune, they still can have Hashimoto thyroiditis, but do not have a low T4 level yet, right? You just find that they have an elevation of TSH. Now, many medications can do this. One of the common medications is valproic acid, right? So you might want to ask the patient, the drugs that are taking, medications that are taking, right? Or this could be spurious results, right? Remember, these hormone testing require a standard curve, right? So when you do a TFT from the same patient in 2 different times from the same lab, you can discover that they have different results, right? Because each time it has to be calculated against the standard curve, right? And usually in certain places, the standard curve is done weekly or daily, right? So it depends on the lab. Now, there's also another a condition that often come up when you are in the ICU or, when patient is critically ill, right? So it's called sick euthyroid syndrome is the old name. The new name is non-thyroidal illness, right? So what is it? So it's a condition where there is a decrease in thyroid hormone production during the time of critical illness. Both T4 and T3 production can be decreased. And also there's a decrease in peripheral conversion from T4 to T3. Remember, T3 is an active hormone. So the body tried to preserve the rate of metabolism, so the conversion from T4 to T3 is decreased. right? So when you do a thyroid function test, it's very similar to central hypothyroidism, right? So you see a low T4 and normal to low TSH. So it's very difficult to distinguish what is the way to differentiate between the two conditions. History, right? You see a patient is critically ill, you perform a TFT, you see a result that looks like central hypothyroidism. It's most likely a non-thyroidal illness or sick thyroid. How do we prove it? We follow the patient and we repeat the test when the patient is back to baseline. Now, there is a controversy regarding treatment of patient with sick thyroid syndrome with levothyroxine. The general consensus is that we do not recommend to treat them because it actually increases morbidity and mortality, right? So you may see that in your intensive care unit rotation. And the last condition that worth mentioning is Graves' disease, right? So Graves' disease is a primary hyperthyroidism, right? What it is a condition where you have an autonomous production of thyroid hormones, right? So you have a very elevated free T4, T3, but TSH is very suppressed, right? So in another word, it's like a primary hyperthyroidism. It's from the gland. So it's actually caused by another receptor, right, that actually binds to the TSH, right? We call it TSI, right? So when you do a TFT, you usually see a very elevated T4 and T3 and suppressed TSH. And goiter is very common, right? So as I mentioned earlier, goiter is a physical finding. It doesn't tell you whether this is hypothyroidism or hyperthyroidism. Thyroid function test will tell us. Okay, so this is just a introduction to thyroid disorder that we're going to go over during academic half day. So it will be good for you to review those conditions again. So during academic half day, we can go over these cases quickly.